So the first thing we're going to discuss is transducer selection. As for this particular exam on the ocular examination, you want to have a linear transducer. That's one that has a flat footprint that goes onto the patient. There's a couple different Zonare linear transducers that you can choose from, which have variable sizes in the footprint that will actually contact the patient. Each one of them is going to have a marker on one side that actually, as the probe marker, give you orientation during the examination. The different transducers are going to have different frequency ranges. So since the footprint's going to be a little bit different, the frequency range is going to determine your axial resolution for the ultrasound machine, or picking out different points. One that has a higher frequency is going to be a little bit more, have better, more clear images of small structures than one that's a lower frequency. However, with some patients who have sunken in eyes, you may not be able to get this entire footprint into a place where you can get a very good image, and you might want one that's a little bit smaller. So it's going to be based on the patient that you have. So there's a couple different ways that you can actually do this examination, and I'll go through all of them. There's pretty much three that are discussed. The first one is you can take a tegaderm and actually put it directly on the eye and then put the gel over the tegaderm and try and image through it. I don't tend to use that technique because air pockets can accumulate below the tegaderm. It can mess up the imaging that you're trying to do of the eye. The other one is you leave the tegaderm off and you fill up the eye socket with a bunch of gel, and then you image through that. That's the second option. The third option is the one that I usually do, and I actually take this tegaderm and you can image through this if you put it directly on the transducer. I like that because it prevents the patient from getting any diseases that might be found on the actual transducer, and when you're done, it's easy to clean up. You just peel the tegaderm right off and the gel comes off with it. So the first thing that I'm going to do here just to prepare the transducer is I will take the tegaderm out of its package, and it has one side that's actually adhesive. And so I'll actually take that adhesive portion and I'll pull it really taut. And I'll put it right over the surface of the transducer and then run my finger right across it to get out any air bubbles. As long as there's no air bubbles in between the tegaderm and the footprint of the transducer, you'll be able to image straight through it. So you want to get all the air bubbles out. And then you just peel off and then adhere it right to the tip of the transducer. And now I can put the gel directly on here and it will actually show up on my screen, and I can image right through that little protective covering. So I just make a clear strip that's very thick right over the surface of the transducer, and then it's prepared to image. When you take the transducer after you have the gel actually on the transducer, make sure you have your orientation marker. This little probe marker will correlate with the Z on the Zonare machine. So the Zonare marker is also on the left side of the image. There's a couple different ways you can do this. You can actually take the transducer marker and hold it directly up to the screen so it's on the same side. And that will let you know that when you go to image a patient, the left side of the marker correlates to the left side of the screen, which will correlate to the right side of the patient. The other thing you can do is take your finger and just rub along that side of the probe, and you can see the gel actually moving on the screen. And that will tell you that this is the left side of the screen correlating to the right side of the patient. So the major reasons that I will use this study in the emergency department are mostly for patients with painless vision loss. So if I'm looking for a vitreous hemorrhage, vitreous detachment, a retinal detachment, the other things you can do is in trauma patients. Trauma patients who are very difficult to examine because their eyes are so swollen are actually very easy to examine with machines like the Zonare, because the swelling will allow the sound waves to get down there. You don't have to pry their eye open. You can just do an examination right across their eyelid, check extraocular movements, and a lot of other things. You can look for foreign bodies in trauma patients. You just have to be very careful that you don't put a lot of pressure on their eye while you're doing the exam. So what we're going to do now is we're going to acquire an image and we're going to optimize the image. We have this strip of gel right here. So whether I'm imaging her right eye or her left eye is going to determine where I brace my fingers. You don't want to put pressure on the eye and cause them a lot of discomfort. So if I'm imaging her right eye, then I'm going to take my fingers and I'm going to stick them right on the glabella and the bridge of her nose to brace myself. If I'm imaging her left eye, I'm going to put it right on her cheek, right here. So we're going to image her left eye right now. I'm going to take my probe marker and make sure it's lined up with the appropriate side of the machine. And I'm going to put my fingers right on her cheek and then slowly lower my ultrasound transducer until the gel contacts her eyelid. Now, when it contacts her eyelid, I can see on the machine that the image is not optimized. It's actually undergained. So I'm going to hit this optimize button, and it's going to brighten up the image for me. The other thing you notice is you want to be able to see the anterior structures as well as the posterior structures all the way through to the optic nerve as it's exiting the eye. So I'm going to bring my depth down to about 4 centimeters. Okay? And at 4 centimeters, I'm going to change my gain so I can get a very good image of the globe. And what you can see is you can see the anterior elements, you can see her lens, So you can see the aqueous humor, the cornea, you can see the iris, you can see the lens, you can see the vitreous humor behind that, both of which are very good transmitters of sound. You can see the posterior portion of the eye, which includes the pigmented and the neural retina. And then you can also see the posterior acoustic enhancement that you get from the posterior portion of the globe, similar to looking through the bladder. And then you can see the optic nerve exiting from the optic cup. The optic nerve is a marker that you need to know because when you're looking for things like retinal detachment and trying to differentiate a retinal detachment from a vitreous hemorrhage or a vitreous detachment, the pigmented layer of the retina and the neural layer of the retina are going to separate out, but the neural layer is going to be tethered to the optic cup because that's where it exits to form the optic nerve. So you're looking for a V-shaped structure along the posterior portion of the globe. So I'm going to have her look straight, and the first thing I'm going to do is get it in a transverse plane through her eye, and then I'm going to image up until I go all the way through the globe, then I'm image down until I go all the way through the globe. Then I'm going to switch over into a long axis view with the probe marker pointed up towards her head. And I'm going to rest it back down again, and I'm going to image to the right, and then all the way back through the left through the entire globe. And then, since the globe is actually shaped like a bowl, you want to make sure that you orient along the axis of your transducer each one of the segments of the eye. So if I'm looking at the superior segment, inferior segment, medial or lateral segment, I want to move her eye in a position so that I can optimally image each one of those. So what I'm going to do is I'm going to go back again. I'm going to put it back on her cheek, and I'm going to get her eye into focus, and now I'm going to ask her to look up. And then when she looks up, I'm going to image up through the globe, and then back down through the globe. And then I'm going to have her look down. And then I'm going to image up through the globe, and I'm going to image back down through the globe. And then I'm going to turn it into a long axis again with the probe marker pointed towards her head. And I'm going to ask her to look towards her nose. And then I'm going to image from the right all the way through to the left portion of the patient. And then I'm going to ask her to look to the left. And I'm going to do the exact same thing. So the reason that I love this examination is if somebody comes in with painless vision loss or trauma, then I can go in and do an immediate evaluation, and then I can call my specialist and I can recruit my specialist down to the emergency department with a specific diagnosis in mind. So it improves my communication with my specialist and also expedites their care.